So now I'm going to talk about screening for pathologic cardiac disorders and look specifically at the performance of history, physical exam, and ECG and finding them. I'm going to apologize right ahead of time. This is an older version, and some of the animation on the slides is messed up, so bear with me. My disclosures haven't changed in the last half hour. So when we think about sudden cardiac death and disorders that cause sudden cardiac death, it's pretty clear that about 1 in 300 athletes will have something that could potentially predispose them to sudden cardiac death. And so if our goal in doing a sports physical or pre-participation exam is to find them, the question really becomes is what is the best way to find them? Is it history or is it history? Is it physical exam? Or is it ECG? We're going to talk a little bit about that. So when we think about a screening test, a valid screening or a good screening test needs to be valid. It needs to be sensitive, which means it can correctly identify those who have disease and have a low false negative rate. It needs to be specific, so it can correctly identify those who don't have the disease and have low false positives. It needs to be reliable, and that's pretty key. It needs to be consistent when performed by more than once or by different people. It needs to be safe and acceptable and cost-effective. And so what we've been doing for the last 10 years or so is, mostly in the sports medicine community, is this pre-participation evaluation. This is the fourth version of this. What's been recommended recently is the AHA recommendations were recently updated, but they're really the same since about 1996. And so these are the history elements that we've been told are going to help us find cardiac pathology. And so when we look at this in terms of our experience, because there's not a whole bunch of literature out there, let's look specifically at the PPE4. When we first started doing this, we looked at a little over 1,000 high school students. About 80% of them are athletes. And on that initial screening questionnaire, which was the PPE4, 68% of them, 70% almost, answered positively to at least one of those questions. After we talked to them, we threw out about half of those positives, people saying, yeah, I get chest pain, but when I take my asthma medicine, it goes away. And we ended up with about an overall positive response rate of 31%, which for a screening questionnaire, you don't want that many yeses. You want yeses in the things that are important. In that particular cohort, 5 WPWs were identified, and 2 of them had positive histories, but it was really unclear whether they were actually related to the diagnosis. And so when I think about a screening test, I kind of think about airport screening. And so you want an airport screener to find bombs or weapons, but you actually don't want to get strip searched every time you go through. And so there needs to be that balance between sensitivity and specificity. So more recently, we switched to using the AHA questions in our community screens at high schools. And the recent data, and this is just preliminary data, looking at the last 3 years, there are about 4,646 competitive athletes, and about 39% of them had a positive response. And this is probably a little bit lower for 2 reasons. One, we changed the questionnaire, and also we looked at just the competitive athletes. And we know as the sort of intensity and acuity of the athlete goes up, the number of positives go down. So by the time you get to professional athletes, they're answering yes to nothing because they don't want anything to be wrong that would potentially disqualify them. They're not that sophisticated typically in high school yet. And so in our athlete group, about 40% of them had a positive response rate. Again, we throw out about half of them after we talk with them, but overall still a 20% response rate. And the questions that are most commonly positive are, do you get chest pain with exercise? About 12% of people will answer yes to that. Do you have unexplained shortness of breath or fatigue? About 9% people will answer positively to that. And the one that's sort of surprising is one that asks about all these different genetic cardiovascular diseases. A lot of people answer yes to them. Now, a lot of people actually really don't have relatives that have these. They're just like, yeah, my grandma has something. She has like, AFib or something like that. And so the question just isn't really very well understood. So the problems with the history really are that the questions have never been evidence-based. They've just been consensus-based. Many of the systems that are listed are really common and aren't necessarily isolated to those with cardiac pathology. And I think one of the major problems for a primary care physician is that there's little guidance and really no evidence on what's a true positive. So how do you take that yes answer to chest pain and decide whether or not it's really important or not? Many of the questions are misunderstood, and then again, it's not objective, it's subjective, so athletes can lie if they have a reason to do so. When we look at physical examination, what the AHA recommendations currently are femoral artery pulses to exclude aortic coarctation, which, when I think about this in a high school or college athlete, it's unlikely that somebody's going to be real competitive with coarctation by the time they get to be a high schooler, and it's not really a very common cause of sudden death in that age group. And so it may not be the highest yield thing to look at. We're supposed to look for physical stigmata, Marfan syndrome, and depending who we have doing that, we either get a lot of Marfanoid-looking people or nobody, because again, that's really variable in terms of how people interpret that. We need to do a brachial artery blood pressure, which is good for a lot of reasons, but not really typically related to sudden death, and then look for heart murmurs. And what we found with heart murmurs specifically is that in a cohort of about 6,500 high school students, about 7% of them had a murmur. And of those 7%, 16, or about 3% of the 7%, had something that was clinically relevant, and about 1% had something that could be potentially lethal. And so we found some things with physical exam that might be potentially lethal or potentially clinically important. The interesting thing about this is that about 85% of those murmurs were characterized as grade 1 or grade 2, about 15% as grade 3 or higher, but there's absolutely no correlation between how the murmur was characterized as being either pathologic or benign, and whether or not it actually was associated with any sort of pathology. So about 1 in 27 kids that had a murmur had a clinically relevant finding. About 1 in 100 kids had something that could be potentially associated with sudden cardiac death. But really there wasn't a very good relationship with the characterization of the murmur and the actual pathology, leading one to wonder if when we hear a murmur in the office where you don't have echo right there, can you really do a very good job, at least from a primary care setting. The people who are listening to these murmurs are not cardiologists specializing in sports medicine, but they're typically residents or community practitioners who are helping us out at our screens. So with history, you get a lot of false positives, and it's really a subjective screen. Characterization of murmurs may or may not accurately distinguish between benign and pathologic things. So what about ECG? Well, when we look at some of our data from ECG, in this prospective trial over 2 years where we looked at 35 different NCAA institutions, we screened about 5,000 athletes, and about 33% just out of the gate answered positively to one of the history questions. About 2.1% had some sort of physical exam abnormality, and about 3.7% had an ECG abnormality. And that was using the Seattle criteria. This was a few years ago. And so what we found, there we go, is that the sensitivity of history was about 15%, and it was only 73% specific, that the sensitivity of physical exam was only 7.6%, and of ECG was about 100%. And so the sensitivity is really differs between those three modalities. And in fact, when we went and we did a meta-analysis where we combined all the studies that looked at this sort of stuff together, the selection criteria for studies that were included in this meta-analysis, they had to look at history, they had to look at physical exam and ECG. They had to use AHA or similar type questions in their history exam. They needed to use some sort of modern criteria that attempted to distinguish from physiologic changes from athlete's heart from pathology. And they need to have definitive testing of abnormalities, not just sort of this many were abnormal. We found 15 studies that met that criteria, included about 50,000 athletes. You can see down the breakdown from the different countries there. The age range was 5 through 39, so again, it's a broad age range, so getting some of the different pathologies in there, which may not be the best. These were primarily competitive athletes, but also included some active adolescents. And what we found again was that ECG was the most sensitive and specific, with 94% over these 50,000 athletes sensitive and 93% specific. And history and physical weren't very good, 20% and 9% sensitive respectively. And when you look at likelihood ratios, which can sort of help you sort of categorize these things, these tests in terms of how helpful they are, ECG had a positive likelihood ratio. So if you had a positive ECG, your likelihood ratio was 14.8, which should suggest that there was a large increase in the likelihood that somebody actually had disease. And if you had a negative ECG, it meant that there was really a large decrease in the likelihood of somebody having the disease. On the other hand, if you looked at history and physical, if you had a positive history finding or a positive physical finding, then there was a small increase that somebody actually had the disease. And if you have a negative history or physical, it doesn't really change much. It means that there's actually a minimal decrease in the likelihood of the disease. And this isn't new news. Back in 1996, Dr. Marin looked at 134 athletes who died from sudden cardiac death. 115 of them had had a pre-participation exam, and only one of them had been identified prior to their death. And his conclusion from that was really that the standard pre-participation screening process, which at the time was history and physical, appears to be limited in its power to identify those cardiovascular lesions that are ultimately responsible for death. And in fact, more recently, people have come to the same conclusion. This is a statement that came out last year. It was the Inter-Association Consensus Statement on the Cardiovascular Care of College Student Athletes. And what Brian Hainline and the panel came up was that there's really limited evidence to support the effectiveness of pre-participation screening with history and physical to achieve the generally agreed upon primary objective, which is the prevention of sports-related sudden death in athletes. And in that AMSSM position statement that John and Fran led, they came to a similar conclusion, that the current history and physical examination, while pragmatic and practice, a lot of us do it, is really limited in its ability to identify athletes with conditions at risk for sudden cardiac death or arrest. And so when we come to the performance of history, physical examination, and ECG, what we can conclude is that history is insensitive and it's got high false positive rates. It's subjective, and there's low inter-examiner reliability. So how I judge somebody's answers may be completely different from how the pediatrician does it in the office. Physical examination is also low sensitivity. And so ECG is really statistically far superior to history and physical for identification of cardiac disease. And so when we get back to this, if this is really the purpose, the reason that we do cardiovascular screening, to identify these cardiovascular regions, I think that it follows that history and physical isn't really a very good way to do it. And we need to think about ECG or decide whether it's really what we should be doing. I think it is, but again, people can argue whether or not we should be screening for this sort of stuff. Thank you, and I just want to put in a plug for a study that we have going. If you have athletes with long QT syndrome or HCM, we'd like them in a registry to follow them, whether they're exercising or not. Mike's involved with this, Ackerman from Mayo, and Rachel Lampert from Yale. So contact me or them if you have somebody. Thanks.